Respected teachers, friends and colleagues, I thank TOSA and NOSA to have given me this opportunity to talk to you about the management of intracapsular fracture neck of femur. Which is next? Next slide. Thank you. Though I have been given the topic to discuss about the closed reduction internal fixation and open reduction internal fixation, there is another talk by Dr. Ved Prakash about more details and technicalities. So I will be mostly talking about the controversies in the intracapsular fracture management. It was Kellogg Speed who said it is an unsolved fracture. Basically because of the fracture being based in synovial fluid, being intracapsular, and that this bone lacks periosteal layer, and that there is eccentric loading. All factors make it more prone for complications. Next point is basically I am going to talk about the management in the young adults. Who are young adults? Those who are less than 50 years for all practical purposes, and those between 50 and 70 who have high activity levels, no medical comorbidities and good bone quality, and they have good cognitive status. These are physiologically young. So the management is more or less same in these two groups. What is important about it? These people have high functional demands and they require preservation of the anatomy and mechanics of the natural hip. In the incidence, basically we have two groups, one young 20 to 40 year group which usually sustains injury in a road traffic accident. Fracture is usually a vertical bowels type 3 type, and the next group is the larger number who have got injury due to the small falls. The well-known classification by Gordon basically has 4 types, and we all know that the inter and intra-rater reliability of this particular classification is not very good. It does not consider posterior cortical comminution, which is an important point in the prognosis. Usually it will be more useful in the elderly. Grossly, we can divide into two groups, the undisplaced, that is the type 1 and 2, and the displaced type 3 and 4. And we all know about the Powell's angle, which basically explains the fracture line in relation to the horizontal. Anything more than 50 is considered as Powell's 3, and the shearing forces are more in this, complicating the fracture union. So the challenges are basically that there is an abnormal, or you should say eccentric biomechanics, and the vascularity is vulnerable in this area. Both of these lead to increased incidence of non-union and avascular necrosis. So the key factors are in the management, under our control are the accuracy of reduction and implant choice and position. And what are not under our control are the bone quality and the posterior comminution. So the goals of management are basically to return to the pre-injury level of function and to prevent the complications. And for this, we have to do anatomical reduction, because this preserves the blood supply and reduces the chance of avascular necrosis, and also we have to provide a very stable fixation, preserving the bone stock and achieving the union. Non-operative management is only for the sickest, and when we try to do non-operative management of those fractures which are otherwise undisplaced, almost 50% get displaced and require surgical intervention. So mostly in all other patients, surgery is the rule, and obtaining anatomical reduction is paramount. Preoperative traction, frankly, even today I have been applying preoperative traction and think that the patient's pain will be lesser, and patient also thinks something actively is being done while he is waiting for the surgery. But theoretically, there is no effect on the analgesic use, no effect on the fracture reduction at surgery. In fact, we add some skin problems, and some people say it actually reduces the intracapsular volume and increases the tamponade. So nowadays, traction is not that indicated. Regional anesthesia is shown to have lesser amount of deep vein thrombosis and reduction in the fatal pulmonary embolism, and this being a hip fracture most often can be done under regional. Timing of surgery is a matter of debate. It helps in early mobilization. It reduces the stay and cost of the patients. There are a lot of papers supporting it, most importantly Swinkowski, who has shown that surgery with less than 8 hours has reduced the incidence of avascular necrosis. An interesting paper was by Jain et al., which shows when the surgery was done in less than 12 hours, incidence of avascular necrosis was 0, and when it was done more than 12 hours, it was 26%. But then there are a lot of papers again which are not supporting the emergent treatment. Again, most importantly, Hajdukovic has shown that when it is fixed in less than 24 hours or in another group fixed later than 24 hours, there is no significant difference in avascular necrosis. Similarly, Razik et al. Have shown when they have compared fractures fixed in less than 6 hours and those which are fixed more than 48 hours, there was no difference. So this is still a matter of debate. So current best evidence suggests a lack of association between the time to reduction and osteonecrosis, incidence of osteonecrosis or non-union. But most of the evidence is from inconclusive, and a proper double-blind randomized control study is required. Coming to closed reduction or open reduction, more important than these two is the anatomical reduction. If you can achieve closed reduction and anatomical reduction, it's fine enough. It has been explained just before about the Ledbetter technique, which we have been following most often before the advent of the image intensifier in our OTs. It reduces the cost for the patient, it is less invasive, and saves the operating time. And more than 1 or 2 attempts are not good for the patient. With the advent of the image intensifier, most often what we do now is restore axial length with traction in external rotation and then internally rotated. So just traction and internal rotation will reduce. The quality of reduction is more important. It is assessed by the Garden's alignment index and the Lowell's Lazius shaped lines. Open reduction helps in direct visualization of the anatomical reduction and also relieves the intracapsular tamponade. We have the Watson-Jones and the Smith-Peterson approach. But there was no difference between the closed or open reduction groups with regard to the rate of osteonecrosis and union. Similarly, in another critical study, they have studied both the closed reduction and open reduction. What is most significant is the incidence of infection has increased in open reduction, and there is no gold standard to decide what is actually in a given open reduction or closed reduction as long as the anatomical reduction is achieved. Now coming to the hematoma decompression, this is another point of controversy. To reduce the intracapsular pressure and to increase the blood flow and after the femoral head, there is no conclusive evidence. It's supposed to, the initial trauma and the initial fracture displacement play a more significant role in the development of osteonecrosis. There are plenty of implants. Choice of implants include the compression screws, fixed angle dynamic implant, combination of these, or a fixed angle length stable implant like the locking plates or the Jewett plates. About the technique of these surgical details, somebody else is going to discuss. So suffice it to say that 3 screws in paracortical places, inverted triangle, and 4th screw only for posterior comminution. Then there is no difference between cancellous screws or DHS for type 1 and type 2. And between DHS and DHS with derotation screw, again, there is no difference for Garden 1 and 2 fractures. Now, dynamic hip screw is supposed to be, particularly with derotational screw, is supposed to be good for Powell's type 3 compared to other implants. Similarly, the proximal femoral locking plate, which is stiff and may not allow collapse, is also very stable and is good for Powell's type 3. But between the two, I think DHS with derotation screw allows collapse and compression dynamically. Is there a consensus? Yes. About 540 surgeons have been questioned, and nowadays most of them do not do open reduction. They do in less than 25% cases. Most of them want to do the surgery early. Undisplaced fractures, most of them will do cancellous screw fixation. Displaced fractures, either cancellous screw or DHS, but those with posterior wall comminution and Powell's type 3, DHS with derotation screw. And this is another paper which actually shows the need for valgus osteotomy, but particularly in osteoporotic patients, whereas young patients with good strong bones, probably it's not required. Inaccuracy of fracture reduction, posterior comminution, and poor surgical stabilization are the failures. So the future directions are basically proper randomized control trials are required. Use of dynamic MRI helpful in predicting the outcomes. Anabolic medicines have some probably future role. Primary bone grafting for comminution and HA-coated implants and medius buttress plates. The conclusions, there is controversy regarding the timing of surgery, capsulotomy, and choice of fixation of construct. But there is no question that anatomical alignment and stable fixation are essential. From the literature survey, we can say that fixation should be done at the earliest. Capsulotomy is not routinely required. Stable fractures, Gordon type 1 and 2 require cancellous screws. Unstable, Gordon type 3, 4 and Powell's require a DHS with derotation screw. Thank you.
Kindly collect your memento here. One request to the speakers, kindly manage your time. Already we are running short of time and it's very late. Thank you.